Good morning, everybody. Thank you to the organizing team for inviting me here to present this systematic review and meta-analysis on Retzius sparing radical prostatectomy versus robot-assisted radical prostatectomy. Which technique is more beneficial for prostate cancer patients? This was from a German group, and I am Dr. Ashish Khanna from the Department of Uro-Oncology at Rajiv Gandhi Cancer Institute. So whenever we talk about the outcomes of patients undergoing radical prostatectomy, often a term of trifecta comes into play, which comprises of oncological control, achievement of urinary continence, and return of erectile function or potency. When we talk about cancer control, the immediate postoperative indicator would be a positive surgical margin, and following that, subsequently, a biochemical recurrence may predict recurrence of cancer. In this systematic review and meta-analysis, a postoperative PSA value of more than 0.2 nanogram per ml on 2 occasions was considered as biochemical recurrence. And for urinary continence, no or single pad usage was used to define return of continence. So going through the abstract, the aim was to compare the functional, oncological, and perioperative outcomes of Retzius sparing radical prostatectomy with the standard robot-assisted radical prostatectomy. The trial, this review included only randomized control trials as well as prospective studies, and no retrospective studies, case reports, or reviews were included. The primary outcomes measured were the return of continence, positive surgical margin rates. The secondary outcomes that were included were the perioperative complications. Finally, the meta-analysis has concluded that Retzius sparing radical prostatectomy has statistically significant advantage in terms of return of immediate urinary continence. However, it also has statistically significantly higher rates of positive surgical margins in patients undergoing this procedure for localized disease. So in the methodology, I'm not sure if we are able to see the flowchart clearly. 2 independent reviewers did the work of data collection, risk of bias, and quality of evidence assessment. The types of studies that were included were only randomized controlled trials as well as prospective studies. And the studies had to at least analyze one of these outcomes, such as the perioperative, functional, and oncological outcomes. After extensive database search, we finally concluded to 4 randomized trials and 6 prospective studies. So the 4 randomized trials and 6 studies were included. The quality of assessment was acceptable for all these studies with minimal publication bias, and risk of bias assessment revealed low to moderate bias only. An important finding was that there was no significant difference in the age and the proportion of patients having Gleason more than 7 between both the groups, which has important bearing on the trifecta outcome. Coming on to the primary outcome in terms of continence, when we talk about immediate continence, which is at the time of catheter removal following surgery, in the forest plot we are able to make out towards the left of the line, one line is the Retzius sparing radical prostatectomy, and to the left is the standard prostatectomy, and we can see that the immediate continence recovery was statistically significantly higher with the Retzius sparing prostatectomy, with almost a 1.8-fold increased probability of the patient being continent. When we talk about the continence recovery at 3 and 6 months, although there is a trend towards better continence with Retzius sparing, however, this was not statistically significant, and the same was seen at 12 months, where the continence was almost similar in both the groups. When we talk about potency returns, it should be noted that only 4 studies out of the 10 reported on potency, and there was no difference in the immediate potency recovery which was seen between the 2 approaches. When we talk about the positive surgical margins, the rate of positive surgical margins overall for Retzius sparing approach was 18%, whereas for the standard approach it was 16%. When we substratify it according to the disease staging, we find that for patients who have a localized disease, pathological T2 or less, the positive surgical margin rates were statistically higher in the Retzius sparing approach. However, this effect was not seen when the procedure was performed for patients who had locally advanced disease. Surprisingly, or not so surprisingly, despite the higher positive surgical margin status with Retzius sparing radical prostatectomy, 2 studies reported higher biochemical recurrence with the standard approach, and the remaining 5 did not report any difference in the biochemical recurrence. And when we talk about the perioperative estimated blood loss, major complication rates, and length of stay, there was no difference between either groups. So to conclude, we find that the immediate continence, that is at catheter removal, is better with Retzius sparing, which may or may not be seen at subsequent evaluation points at 3, 6, or 12 months. There are a few limitations of the study, that inter-surgeon heterogeneity could not be assessed in these studies, which is a very important factor when we assess a surgical technique-based study, because Retzius sparing radical prostatectomy has a steep learning curve. Galfano et al., who have reported about Retzius sparing, have said that almost 100 cases of this procedure need to be done before the positive surgical margin status comes to a level. Importantly, the use of preoperative MRI was not a standard practice in these studies, and as all of us surgeons know, when we are doing radical prostatectomy, the know-about of the location of the tumor is very critical in deciding whether Retzius sparing approach should be followed or not. At my center, we are routinely doing Retzius sparing, and we make it a point that patients who have anterior disease or disease that involves the bladder base, we seldom perform Retzius sparing approach, because it is difficult to see within the bladder by this approach, and it is difficult to take an anterior margin. Also, definition of potency was not standardized, and also it should be realized that potency is not a factor that just depends on the surgical approach. It depends on the patient's preoperative potency status. It depends on whether nerve sparing was performed or not performed, and whether it was accurately assessed in the postoperative period as well. Thank you so much, and that's the conclusion from the study.